considered an expert with two such great personalities sitting here with me and all of you. Maternal mortality is one of the most pressing problems, and as our past president Mahmood Fathallah had mentioned, women are not dying of diseases we cannot treat. They're dying because we are not taking decisions which would save them. And we have an expert, none other than Sir uh, Arulkumaran, who we have heard on many other topics. And we have none other than Dr. Kawita Bapat, who is doing this wonderful academic session. And this is such an important topic that I'm sure is going to help us to get a global and Indian perspective into maternal mortality and what we can do. And, as they say, each one saves one. So if even you can make a difference to that one person, I'm sure it will go a long way. So Kavita Didi, over to you for
Yes,
taking the session.
thank you so much. Thank you so much. Please remove my CV over there so that the screen will be full of, yeah. Thank you so much. So good evening, everyone. Thank you so much for again joining today's session, Tuesday Tea Time, Learn Simply. Our idea is very simple, to have crisp and smart way of putting the things simply. And really, it's my proud and privilege to introduce our guest. You cannot say the guest, the big, what I should call the most humble and the dynamic personality of the world. It's really a proud and privilege. Because when we have to do a dialogue of the maternal mortality, which is a very key, important thing for our country, and really I want to extend my warm reports to Sir. So welcome, Sir. You have received so many fellowships and honors and exemplary work into the improving the healthcare of the women across the world. You are the recipient of the professorship. Because the audience should know, sir, the name of the countries you are having the visiting professorship, right from Australia, India, Malaysia, Singapore, Japan, America, and Canada. You are an honorary fellowship of American, Sri Lankan, South African, Pakistan, India, Australia, New Zealand, OBGYN, an honorary member of Canadian, Malaysian, German, Italian, Spanish, Japanese, and South African societies. And you have an honorary Doctor of Science from the University of Athens, Greece, Colombo, Sri Lanka, that's Colombo, Sri Lanka, Sweden, Ukraine, and St. George's University of London. You have a great honors from various countries. You have a great honor from the UK, has been given to the service to medicine by the Queen on her birthday honor list. Sri Lankan, this is Ranjana National Award, Cyprus Active Citizen Award, and Professor Emeritus of St. George's University. And so many things are there. So you're author of 300 index publications, which is very, very important. Nobody has done. And a past FIGO president, which is very important. President of many more places, but FIGO president for us. And a guidance and experience in the field of women healthcare. We can understand how to reduce maternal mortality and our country. So really, sir, honestly, I am blessed to have you today with us. And we will have a small dialogue, sir, which is not a simple dialogue, which will we do. As a maternal mortality is a key indicator of overall health and well-being. And it reflects the quality of the healthcare system in the country, and high mortality rate usually associated with what the problem with our country is, a poorly assessed healthcare service. So, sir, my questions will be very simple, and you are there to make it more simpler for everyone. Sir, what you say that in our country, the main reasons for high mortality and how it should be addressed?
Thank you, Kawita, for asking me to join you today and for the kind introduction. First of all, I should congratulate India, the government of India, plus the obstetricians and the healthcare personnel for doing so well. Before I start the answer, the topic is maternal mortality, so I would like to give some figures which are very reassuring. The maternal mortality of India was 130 in 2016, came down to 122 per 100,000 in 17, 113 in 18, and in 2020, it was 97 per 100,000. So which means it is progressively having a reduction of 3 to 4% every year, so which is fantastic. But the global maternal mortality is 211 per 100,000, compared to India is 103 per 100,000, in 2017. So India is doing extremely well. And they will reach the SDG goal of less than 70 by the time it comes to that. But I think, as Kawita just mentioned, the worrying trend is, and also our good friends from Delhi and other places, the lowest maternal mortality in India is 19 in Kerala, 19 per 100,000.
Yes, yes.
And 33 in Maharashtra, 43 in Telangana, and less than 70 in Tamil Nadu. So the four, Kerala, Maharashtra, Telangana, and Tamil Nadu, are doing very well.
Yeah.
The one which are failing behind, Assam. Assam is the highest, is 195 per 100,000. And Madhya Pradesh is 173 per 100,000, and Uttar Pradesh is 167 per 100,000. So these are extremely high, because if you look at the 1947, before independence, maternal mortality, there's an estimate was 200 per 100,000. So Assam, Madhya Pradesh, Uttar Pradesh hasn't done well. And the UNICEF did an analysis of the causes, which is your question really, as to what the major problems. And the major problems are poverty,
Yes.
less education in these setups in Madhya Pradesh and Assam and Uttar Pradesh compared to Kerala, Maharashtra, and Telangana. So poverty, less than optimal education, empowerment of women to get jobs and do the things. So that is a basic problem. But the medical problems are anemia, hypertensive disease, bleeding is one of the, and abortions, which are not done properly. So that is also a contributing factor. So the causes are similar, that you can put it on three baskets.
Yeah.
Too many children in some of these places. The fertility rate in India has come down, but in these countries, cities or regions where the high mortality, the fertility rate is high, anemia, then hypertensive disease, bleeding. Bleeding is the predominant cause, even much more than hypertensive disease, and sepsis, and incidents related to abortion. So your question was, how can we resolve that? I think there are long and short-term solutions to look at.
Absolutely, sir. Absolutely. I come from the state which is Madhya Pradesh, and I'm feeling bad that we are having one of the highest maternal mortality in the whole country. And probably, sir, just I'm putting one word, because of some tribal and rural areas with the pockets into the Madhya Pradesh, and the problem with them, they are having not institutional delivery. They still deliver at home. That is one of the reasons probably over there. And the cesarean section rate is also low in Madhya Pradesh in comparison to also. I'm not making both the things together that I have raised the cesarean section, but this is the problem. So thank you so much for this point, sir, that the poverty, education, and empowering the females are the important thing, and other things are. But sir, in a general that you have seen, you have traveled all over the world, seen things, you teach, you talk about. So the message, but how can we improve the access of the quality maternal health services in the rural areas of India? So many efforts are already being done. So many things are already done, but still we want a few important points that we should have, that how to improve and access the quality healthcare services in the rural areas of India.
So I think we have to go back to the original maternal mortality issues raised by Mahmoud Fathallah and the team from Colombia, that we had to map these areas with high maternal mortality and see whether for 500,000 population, whether there are at least 4 primary healthcare centers. And for 4 primary healthcare centers, there must be 1 comprehensive healthcare center or hospital. And these 4 primary care health centers should provide basic emergency obstetric functions, which is 3 injections, IV magnesium sulfate, IV antibiotics, IV oxytocin, and then the facilities for treating incomplete miscarriage, normal vaginal delivery, and instrumental vaginal delivery. And comprehensive one should have blood transfusion and cesarean section. Yes. So if you map these areas, then there might be a problem with the maternity ecosystem. Maternity ecosystem meaning community on one hand, and the hospital on the other hand, And the transport is one problem, finances are another problem. So how do we resolve the transport and finances? So first to map the area, then the third issue is to talk about the personnel. We know that I think from the Indian government statistics, there are 2 million nurse midwives and 900,000 auxiliary nurse midwives. But the question really is, are they distributed in these areas like the Andhra Pradesh, Madhya Pradesh, and so on? And are they capable and trained and doing the emergency obstetric functions? Because if they can be trained, but they may not have the facilities, the oxytocin drug or magnesium sulfate, and so on. So I think it's to map out and to look at the health facilities, look at the people, and then whether they are trained to do a particular function and whether there is enough medication for them to function. So that's the only way we can really proceed
Absolutely.
to reduce further the maternal mortality.
So basically the transport, finance, and proper infrastructure and treating of the midwives. Am I right, sir?
The training of midwives so they can function.
Yeah. And the availability of drugs.
Availability of medications
at the primary as well as the comprehensive health centers.
Absolutely. Absolutely.
Yes, yes, sir. So, but now the problem comes that so many, there is no standardization, nothing like that. So how can we, the technology can be play the important role in reducing maternal mortality? So we talk about so many things, everybody having the smartphone, everybody's having things. The India is brewing, India is blooming, India is shining, so many things we talk about. But when the point of reducing maternal mortality, does technology will help us in doing some few things?
Yeah, technology is already helping us, Kawita. You know, we use a simple blood pressure machine to check the blood pressure. So now things are available very freely and very small sum. There are machines which can do hemoglobin percentage without difficulty. So the technology can help us to improve the basic obstetric care.
Yes.
I mean, the 50 to 60% of women in these setups are anemic. So if we can pick them up early, and it might be either due to helminthic infection, or they might have heavy menstrual bleeding, or they might have poor nutrition. We had to really tackle these underlying causes of iron deficiency anemia and then see whether they can have an optimal hemoglobin and not anemic at the time when they come for delivery. Absolutely. And one of the unfortunate things is actually people always talk about anemia kills women, but anemia with bleeding kills women because the anemia per se, even if the woman has 2 or 3 grams of hemoglobin, if you can maintain a blood volume, she doesn't collapse. But if you allow a hypotension to take place, she will collapse.
Okay. Yes.
So the key issue is actually IV fluids also an important component in these primary healthcare centers. So the midwife should be able to give oxytocin, IV fluids. Now, of course, tranexamic acid has come. We can give it intramuscularly as well. So I think we have to really train them, provide them, and make sure that they are not anemic in the first instance. And even if they come anemic, then they are tackled and not to allow hypotension to take place.
Absolutely, sir. Absolutely. So the technology, we should be able to, with the technology, we should be able to diagnose more and more anemic patients as early as possible. And we should be able to make the fluids and everything available. And with the help of technology, things can be done. But the problem with us is that we want to improve many more things in many aspects, but how to improve the skills of the healthcare workers to reduce the maternal mortality, because we don't have the standardization techniques or some quality assurance things which we needed. Means there, I don't say there are Lakshya, there is a Manyata, there are several things are coming up with the government is doing several things. But any point which you say that the training and the skills of the health workers, how to train them to reduce the maternal mortality?
I think, Kawita, the issue is actually the centers which are well provided with higher education, good social and economic status, the training and education is doing well. But when we go to the areas with high maternal mortality, that is not available. So we have to focus our attention on training. Is not only I'm talking about simple things like a digital blood pressure machine or a hemoglobin machine and so on. But as you mentioned, telephone is an electronic device, which is quite important for communication and transport. So we had to think about communication and transport to avoid the 3 delay model, and also to have somebody available when they come into the hospital or primary healthcare setup to take immediate care. So I think the technology plays a major role, not only before the woman comes, but to arrange by telephone the communication, the transport when they come in, even within the hospital, because doctor will be somewhere, midwife will be somewhere. How do we get hold of them to come and attend? And then simple things like the technology of IV fluids, the relevant antibiotics or magnesium sulfate or oxytocin and so on and so forth. So technology is important, but we have to focus on where it is lacking, and in both technology is lacking, the medicine is lacking, the personnel are lacking, and the training is lacking, and try to improve that.
Absolutely, sir. Absolutely. So you basically we need some policies for a few things. And what other countries are successfully initiated those policies to reduce the maternal mortality. So how can we as in India, we can adapt their policies or their, you can this, I mean, in my words, style, or in other words, we can say, how can we improve these things, or we can use the policies or initiatives by other countries?
Well, I think India is a big country. There are 27 million births on an average per year, plus nearly 10,000 odd abortions and so on and so forth. So it's a huge burden for maternity and early pregnancy care. But if you miniaturize that into Sri Lanka or Malaysia, because Sri Lanka is not even the size of a state like Kerala, might be even smaller than that.
Yes.
Their model of care is midwifery based. So the midwife, there is a midwife for every 5,000 population. And she is given a motorbike or scooter to go around. And when somebody has a wedding, there's a drum, a special drum and a decoration. She knows somebody got married, somebody died, she knows there's a separate drum and so on. She makes a note of it. And then she visits those places to see whether it's not a maternal death, and also there's a wedding, whether she needs contraception and so on. And she provides the antenatal care at home, and if there is any, and they are trained, so regularly trained to check the blood pressure, hemoglobin, and also they give vaccinations for the children as well. Only the intrapartum care takes place in the hospital. So there are about 10,000 midwives in the island, only about 700, 800 obstetricians, but these 10,000 midwives are completely trained, and they're checked and they go for retraining in the hospital and so on. So if we can bring about a picture like that, and the same applies to Malaysia, because the figures are about 30 or under 30 per 100,000 maternal mortality. So as you mentioned, the infrastructure is quite important, but the terrain of the country, but I mustn't say only the health structure, because the literacy rate comparatively is much higher. So they will seek care much earlier. The distances are much shorter. So there are lots of advantages being small, but we have to emulate that by saying, if you train so many midwives, are they capable of handling all the emergency obstetric functions? Do they have the medications? Do they have the technique? And so I think we should try for that.
Okay. Yes, sir. You means again and again we go and end up in a thing that the good midwives, good training, good literacy rate, good empower the females, and make it as a routine to do those things is very, very important. But this point is, we are not able to make that much awareness about the importance of maternal health care among the women and their families in India. There's so much disparity. If one in a Mumbai, they say we are doing so much great. But come to the Khargone district of Madhya Pradesh, then you'll find out that we are not able to make the correct awareness and the importance of the maternal health care among the women and their families. So any point or anything which you like to talk about on this subject?
Well, I think we have primary points like universities or schools where the children go to school, and if they have, after the age of 10, 12, they have a better absorption capacity. and whether we can have education programs for children in schools about the issues related to menstruation, issues related to feeling tired, issues related to getting pregnant. Because if you look at the figures in these 3 or 4 places which I mentioned, if you look at 15 to 49-year age group of women who die, roughly 30% are related to pregnancy.
Right.
But if you take the age group of 15 to 20, 50% are related to pregnancy. In other words, adolescent marriage is also an issue in some of these settings, in the places we mentioned. So I think education, if they can be promoted to carry on schooling, for example, so they don't get married, and if they do get a job, then they are more interested in doing what they pursue. So there are many angles, and so there's not one simple bullet to treat the problem. So it's education empowerment is the basis, but then we have to find ways and means of how to bring about the change.
Correct. It's a basic whole social engineering of that area, you can say, right? Absolutely. From education to importance of the healthcare and the importance. That's what we have in our countries so many issues. Gender biased, we are not equality, so many things are there. So we are not going into it, that's also because they are not good to talk about, even because sometimes we should not talk, and the violence against females are also there. So many social engineering is a different in India. But sir, just our this audience, or you can say our obstetrician and gynecologist, would like to know, then in simple words, that how can we improve the quality of emergency obstetric care? See, that's also very important. Then how we can improve it?
I think Foxy has been doing a wonderful work from D.K. Tang's time when he was Secretary General, and then President. He started with the Ministry of Health, and then Sadhana Gupta took over. And there have been a lot of emergency obstetric training. So that should continue, because the cadre of staff, the midwives or doctors, are always changing. So new people come in, so they should have a refresher course and so on. They should go in. But the issue is actually, how do we check whether they are doing what is taught to them? So in a pilot way, not in all the districts and all the hospitals, in a small area, we had to do 3 audits: audit of the structure, audit of the process, and audit of the outcome, to see whether the structure is able to cope with what they did for training, whether they have got magnesium sulfate, antibiotics, oxytocics, tranexamic acid, and so on. And secondly, are they doing it? Are they giving? So if they get a case of hypertensive disease or PPH, to see from the notes whether they have been checked. Now, I visited Mozambique a couple of times, and the adolescent pregnancy rates are high, and eclampsia rates are very high. And when I look at the clinical notes, there is no recording of blood pressure when they came to the antenatal care, which they would have picked it up much earlier. So I think the process, whether they are doing what they are supposed to do, check the blood pressure, give oxytocin, give magnesium sulfate, give antibiotics, that has to be checked. And then, of course, finally, the outcome. How many maternal mortality is it reducing? And of course, the transfer rates of women to another hospital. So I think it's an elaborate process. You can't do it, but you can take segments of it and then try to do some evaluation.
Correct. So you're absolutely great, because we need a guidelines, we need a auditing of all programs, we need the proper checklist, and skill and training is another important point. And at the end, outcome is very, very important, as you said, and when to refer the patient. So the last question, sir, and other than you also want to add anything, we will like to listen about it. But the important steps which we need, I think this is a question is little funny, but it's important, sir, that what the government and healthcare professionals put their points in reducing the maternal mortality. This is my last question, because at the end of the day, we have educated the female, we have given the infrastructure, we have trained the midwives, so many things are there, but still few points which government and healthcare professionals should do to reduce the maternal mortality in India.
That's an important question, Kawita. The way I look at it, and which I have introduced in some other parts in Africa and so on, is there are 5 components we have to think about if you want to improve the maternal mortality. Number one is to form a strong coalition between the professionals, the government, women's health services, some other interested parties like stakeholders and NGOs, so that they meet regularly, at least every 2 months, to see what is needed in maternity care, what is lacking, and why did the woman die, or whatever it is, and try to do something. The second aspect of that is actually not to introduce a lot of things at the same time, but only one thing at a time and incorporate into the system, what I call as bite-sized intervention. For example, now the e-motive is becoming important for management of PPH. So you can introduce e-motive in all the centers. So that is the bite-sized. And the third is ownership. So who in the local facilities is a champion or the owner to make sure that it happens? Because if it is left to everybody, then it falls between the cracks. But if somebody is put in charge as a champion and ownership, then it works. The fourth is actually to see whether you can get some additional public-private partnership. Some corporation like Rotary or some other organization can help if there is any deficits. And finally, some sort of measurement, which I mentioned as audit. So and not only just measure, but some reward system, like giving a certificate from Foxy saying this health center has done fantastically well, or the government hosting a tea party to that organization which had done well. So its measurement and reward is also quite important. Then people are constantly aware. So these are the 5 steps I think are important to really gear and put things in place if you identify some. And it might be that you introduce emotive, the next year you might introduce hypertensive disease or something else, and press on with the same structure.
Correct. So I think the message is good, and because the reward system, the stakeholders, the funds, and the emotive which you talked about, all are the very, very important point. We have Dr. Reena also with us. So Reena, please continue with asking some few questions, and we can do from the chat box also. We had a great time, sir. So you have given the answers, and it was very crisp, and probably I tried myself to cover the maximum points. Reena, any points which in next 3 minutes, which we can cover?
Thank you, sir, for highlighting the 5 components. And what you mentioned about audit. One of the reasons why Maharashtra has reached this is probably because we have a facility-based maternal death review. Make each and every death auditable at your own center. And then you have a district quality assurance committee. So, sir, what is your experience internationally? That are there such central and local audits, and how does one implement those? Because I feel that without fault finding is one of the very important ways of finding what went wrong and at which level.
Yes, so in the UK has a tradition from the 1950s to have 3 yearly audits of maternal deaths. And also in the Sri Lanka, for example, they have maternal death reviews, and Malaysia has, Kerala has, and so on and so forth. So they have hospital reviews, regional reviews, and the country reviews, depending on where it is. So the people who are reviewing don't have identity of the individual woman who had died, but they make a recommendation based on a group. So they group the number of cases of PPH, a number of cases of preeclampsia together, and find what is the common thread, why this woman had died, this woman had died of preeclampsia or sepsis. And they make the recommendations, and they find out whether there is a problem in terms of the structure, the process, so that they can pump in some funding or training or something like that to alleviate it. But overall, there has to be what you call as a clinical governance structure, like simple ways to, if I stand with my arms and legs stretched, one arm is actually the structure, the equipment, the medication. The second arm is actually the individuals. Have you got enough staff, and are they able to manage? And the body is actually the guidelines, the audit, and training, education and training. And the 2 legs is actually risk management and complaints. So you have to really look at all 7 components there. And the leadership, of course, is the head. So you have to really think So I think it's quite important in maternal reviews to think about these things, whether there's a lack of the structure, lack of process, lack of guidelines, lack of audit, lack of education and training. And based on that, you can really adjust what can be done.
Amazing.
Thank you so much.
Amazing.
I mentioned our past president, Dr. Sadhna Desai, who had started the Emergency Obstetric Care Initiative. So, do you feel that in our country, we should train our ANMs and the people at the primary health centers about the golden hour? And which oxytocin would you recommend that we kind of implement at the centers which are not that well equipped to empower our staff to look after the women under their care?
Now, that's an important area in the sense that under the basic emergency obstetric functions, we are talking about IV magnesium sulfate, IV antibiotics, and IV oxytocics. But these IVs can be given intramuscularly because these same drugs are magnesium sulfate. You can give it in the gluteal region. You can give IM antibiotics. You can give IM oxytocic. And now we are tranexamic acid. So, and the commonest reason why women are dying or bleeding. So if you can train them to give IM oxytocics and IM tranexamic acid, which is equally good like IV, then we have done something useful. So the basic emergency obstetric functions, we have 3 injections. We can make it 4 now, and 3 manual functions. Even if the ANMs can make the 3 simple injections and train them and permit them to do that, then we can save a lot of lives.
Amazing. Yes, sir.
Thank you.
Thank you so much, sir. Thank you, Reena. We have a really, it was a good discussion probably, and I think we will make it as a YouTube so that many more can listen to it. And for anybody wants any question, but we are not giving, Dr. Archana Baser is there. Archana, any question from you?
Ma'am, unmute yourself.
Yeah, I just have to make a comment that it was really wonderful listening to Prof. Arul and Dr. Kawita. Really put up very good and very important questions, and we have good take home points from this tea time chat. So congratulations, Dr. Kawita, and thank you, Dr. Arulkumaran, for being with us, and thanks, Reena.
Thank you so much, sir, for being with us. Really, it's such a simplicity and the humbleness of yours. A person like you on a simple WhatsApp invitation can come. I don't have words what to say. Thank you so much, sir.
Thank you very much, and all the best to you. Thank you.
Thank you so much. Thank you so much.
Thank you.
Thank you so much.
Bye.